Okay, everybody, welcome to what I think is our fifth webinar in this series.
Recording in progress.
All been very well attended so far, which is great. And this evening, I'd like to welcome to the group, in fact, one of our trustees of WMUK, Professor Guy Pratt, who works at Birmingham, in the hospital at Birmingham. He's a WM specialist and, as I say, one of our trustees. And he's going to talk to us tonight about WM guidelines and the patient pathway. Guy, welcome to the webinar. It's lovely to see you.
It's a pleasure.
And thank you for giving up your time tonight. And I'll let you crack on. You've got your slides ready, it seems. So I'll hand over to you. You're going to tell us first of all about guidelines, which I think are due to be updated.
Okay, so there's actually a very nice summary of guidelines in the WM newsletter, which you probably all got. But I'm just going to briefly go over what guidelines are. They are recommendations that guide doctors and trainees, healthcare professionals in how to treat and manage conditions. They're almost always published in a journal. And obviously in this day and age, they're available electronically on the website of the journal that they're published, or the organization that publishes them, their website. So the guideline on WM, the BSH guideline, covers everything from making the diagnosis, staging investigations, what therapies to choose.
Recording.
And supportive care as well, and how to manage the side effects and problems that can occur. Guidelines do get looked at by other organisations as well. And the idea of a guideline is that it helps improve the quality of care, in that wherever you are in the world, you can look at the BSH guideline, and we're all humans. We can't remember absolutely everything about every aspect of a condition, and they're particularly useful, I think, in conditions that clinicians may not see as often. So the idea is that they're driving up improvements in care. I think an important point to make to all of you listening is that actually they are a bit of a Bible as well for trainees. So trainees in the UK, they sit exams. They have 2 exams in haematology, and they use the guidelines as a revision exercise. And the guidelines are often, the questions are often around the guidelines, the latest guidelines. What I'm less clear about is how much they're used internationally. Of course, they're highly respected, the BSH guidelines, and I'm sure they will be used internationally, but I haven't really got a handle on that. So guidelines are made by so-called experts, and the first step is to form a group of people who are engaged and driven to do it, and we call that a writing group because they do the writing. And there's a proposal is sent forward to the BSH, British Society of Haematology, who will accept it if they think it's worthwhile, and maybe give advice. And then that writing group gets together and they will divvy out work. So, for example, I might be given supportive care to look at, or Dr. Desar will be given looking at newly diagnosed patients and how we treat them. So Roger Owen, for example, who's very strong in the diagnostics, would be given the area of the initial diagnosis and the bone marrow interpretation. They're evidence-based, so it requires looking at all the literature and trolling through the literature and making recommendations based on that. It can be difficult. The evidence is not always strong, and you need help. So British Society of Haematology does provide help in terms of doing the literature search, which is actually quite a lot of work. And there's various online publication sets such as PubMed or Medline, where you put in a keyword and it will search up all the relevant research in that area. It's really important that the people who write guidelines have a ability to evaluate the strength of the evidence and understand whether a recommendation should be strong or not. And interestingly, if you do a NICE guideline, for example, you get to understand the wording. So offer is when you should be doing something. If you should be offering a patient a CT scan, that means you that should be almost mandatory, whereas consider is a lot more woolly and is much more down to the individual situation. You need to involve the right people in the guideline and make sure that you engage all the right groups. So for example, a myeloma guideline, you would involve Myeloma UK. For a Waldenstrom's guideline, you'd involve WMUK. Maybe not at the beginning, but later on in the process, certainly. NICE is slightly different because NICE take it a step further and they look at health economics, which we don't have the capacity to do that well. And they'll look at working out cost effectiveness, which is actually very specialized. It is quite a process. It's very important in order to produce a high quality guideline, and it goes through lots of drafts. So it gets sent out at repeated stages to experts and undergoes lots of changes from the initial draft. So people get quite experienced at this. There's a very, should I say, I have to use my wording correctly. She's now retired professor at in North London, who is fantastic at looking at the grammar and spelling and corrects all of that. So we do have some very good people who have particular expertise in areas that are used. So I think guidelines are really very important, and they should be looked at by your doctor because they are evidence-based. They will help in decision making. They are advice, they're not obligatory in any way. And it's often quite reassuring as well. I mean, if you're a doctor, you're always worrying whether you're up to date or not. It's something that always worries me with the fast change in practice in different areas. And actually, if you have a new guideline, often it's just reassuring you that actually you haven't missed any new information that's come out. As I say, they're not obligatory. And there may be times when you feel that the recommendations aren't suitable for a particular patient. And obviously then you need to be involving other healthcare professionals to make that decision, usually at the MDT, for example, where all patients are discussed. As I say, the guidelines, so for the British Society of Haematology guidelines, they're on the British Society of Haematology website. And the last guideline was 2014, and we're about to update that. So this is the one that's coming out. It's really been a pleasure to work with these guys, but it's taken an awful long time to get this guideline, unfortunately. I think we're all a bit time poor, but it's fairly advanced now, so we've got a draft and it's been through several reviews, so it's not too far away from publication. I think it's important to distinguish guidelines from NICE appraisals of drugs, because they are although there's some overlap, they are very different. So NICE appraisals of drug is given the word technology appraisal, which I'm not sure is particularly easy to understand the terminology, but technology appraisal is basically appraisal of a drug, and that's very, very different to a guideline, because they're actually deciding if the NHS is going to fund a drug or not. And in that context, there's a big difference between a drug that's licensed and one that's NICE approved in the UK. So drugs such as brutinib, for example, can be licensed up front for WM, for example, or CLL, but it may not be necessarily approved by NICE. And new drugs generally always get looked at where all the research is done initially, and that's usually in relapsed patients at first. And NICE are very good at looking at the evidence. They're very thorough, but they are incredibly slow, which is the big issue for me, is that they always lag behind. So a drug can get licensed, but it can take quite a long time, maybe even years before NICE get around to looking at it. So it's different to a guideline. They'll look at cost effectiveness, they'll compare it to a standard treatment, they'll be looking at quality of life in more depth than probably we will in a guideline, and they're making decisions about whether a drug should be funded or not. The other criticism of NICE is that they look at a drug in isolation and not at a pathway, which is becoming increasingly challenging if you've got lots and lots of treatments available and the pathways are very complicated. So this is the kind of recommendations that you get. Some of them are a bit dull, sorry to use that word, but you know, they're obvious. So obviously you need to do a bone marrow to diagnose WM, for example, and you know, where it should be, you know, how the diagnosis should be made, etc. And then there's recommendations around whether we should do family screening, for example, which we don't recommend. And then around the tests and investigations that we should do. I'm not going to spend a lot of time on these slides, but it just gives you a flavour of what the kind of things that you recommend in a guideline, about monitoring, about what tests you should be doing and when you should be doing them, and it's guiding you in that sense.
Roger, that slide you just showed before, is that effectively the numbers that we all talk about when we're that one there? Yeah, those we all get obsessed with those numbers when we're going in for our 3-monthly check. It looks like a lot of those are those tests, aren't they, that are done on those blood tests? Yeah,
so full blood count, IgM is the key one, and obviously we do biochemistries, like it's such a common test that's done every time as well. Recommendations about CT scans and when to do them. Also about genetics and flow cytometry. So I don't really want to go through these in great detail, but you can see the what guidelines look like. So there's different ways of saying the strength of a statement. So grade A1 means that it's a strong recommendation and there's very good evidence for it. But as you can see, when it comes to treatment decisions, often the evidence is not that strong. So the strength of the recommendation may be different. So the staging system for WM is, unfortunately, I think it's, fortunately, well, I suppose you could say, because the brutinib's come along, but the old staging system, I think, is a little bit in need of an upgrade in the era of newer agents. So it gets a slightly weaker although it's worth recording, it's not actually as powerful. And then things like complications of plasma exchange, when you should do that, how many procedures and what volume of plasma you should exchange. Again, so fairly straightforward. But you can imagine if you're a doctor in a smaller hospital and you haven't seen a new patient for a while, with the best will of the world, you can't be remembering absolutely everything in hematology. And if you've got access to this guideline, it is extremely useful and reassuring, because it may be that you actually think you know what you're doing, you just want to be absolutely sure. So this is where it gets difficult, is when we start to get to treatment. And I know this may come up in questions, that we have lots of treatments available, but as you can see, we've said that all these are acceptable frontline treatments, and that's because it's very difficult to say this treatment should be used here and that treatment should be used there, because we just don't have the evidence to know that, because there's a lack of trials. And also about monitoring the IgM paraprotein, which is very important, because it can go up when you start treatment with rituximab. And then about assessing response and clinical trials. It's very important in particular to do a bone marrow, and it may be that a bone marrow may be needed. You may be able to get away with a bone marrow, but certainly if you have to be absolutely sure of the response, then you do need to do a bone marrow. And then again, relapse. So in that situation, I put BTKI, so that's ibrutinib or zanubrutinib, acalabrutinib. It's those drugs which become the mainstay of treatment now. But again, we're not being prescriptive here, and there's a lack of randomized trials, so it's very difficult to say one's, but you should be doing this or should be doing that. And then lots about transplant as a potential option. Again, perhaps slightly woolly. It's a feasible option to do a transplant, but we're not saying that it's necessarily suitable for every patient and needs to be considered on an individual basis. This one I think will change. I'm not sure people do a neurological examination every patient. I think you should be doing it if patients have neurological symptoms. And if they do, then you should be working with a neurologist doing nerve conduction studies and blood tests looking for antibodies against the nerves. And then this cold agglutinin disease, these are all sort of rare complications associated with WM, but it's about how you should be treating these. Cryoglobulinemia, again, this is when the protein comes out as in the cold, and it's about identifying those patients and then how you should be treating them. Quite a bit on supportive care in the guideline, particularly around managing infections, vaccination, offering vaccination, which I don't think we're very good at, to be honest, in the UK. And then against what antibiotics people should be on when they have treatment, and a bit about COVID as well, which is I think it's a little bit woolly, because it's very hard to be prescriptive about treatment decisions in a guideline in this current COVID climate, because it's going to come down to individual patients and their situation. That was very brief. I just whizzed through guidelines, but I'm really here to take questions, really.
Okay, Guy. Well, thanks for that. We didn't have any questions sent in, but I sent you a couple earlier today. But just going over what you've just talked about there, one of the big in meeting some of our WM family, one of the big, I use the term criticism, is if they're not at a centre like you or in London or me in Bournemouth, the people that are in the outer regions of the country are coming across clinicians who, as you alluded to earlier, might only have 1 or 2 WM patients. Can we be confident that those guys, those ladies and gentlemen have got these guidelines and that they are aware of them and sticking to them? Because sometimes our people are saying, they go in and they just get there, oh, your readings are good, you're feeling okay, see you again in 3 months, and there seems no further in-depth investigation. And what's your view on that?
I actually think it's I'm going to be brutally honest. I think it's a very difficult situation. I think these doctors have trained for a long time to be hematologists, and they are all a range of personalities, as humans are. Some of them will be very open, and hopefully most of them will be kind and caring, and will be open to the idea of getting a second opinion, which you're all entitled to, and I think that's really important. You will get the odd person who will be a bit resistant to it, I'm afraid, and I think that's inevitable in life. But I do think you're right. I do think you probably have to be quite brave in that situation and polite, but obviously, and say, I'd like a bit more information about WM. The WMUK exists, and I've had advice from them, and they suggest that I need to know a little bit more about this disease. I'm quite open to getting a second opinion at a larger centre, and hopefully they should be receptive to that. I mean, I think that the way that life's going is that it's impossible to be master of everything in haematology. It's impossible to manage patients who are having deep vein thrombosis or need a blood transfusion, who have acute myeloid leukemia. The breadth of what we do and the number of drugs that are around, it's impossible to be a master of all that. And that's what these big hospitals are here for. We're here because we're more specialized. We deal with only certain areas, and we go to the conferences, and we do the research, and I don't think there's anything wrong with that. I think it's just a question of being really, I'm afraid it's about in a polite and nicer way as possible, just asking your doctor, can I have a bit more information about this?
Yeah. And so we could go in armed with our copy of the guidelines, and if we're clever enough to identify something that he or she has missed, say, well, what about this guideline here? Have you considered that? Is that being brave, or is that just being stupid? I don't know.
No, that is absolutely right. And it may be, I had a patient last week who just wanted reassurance. There's actually nothing wrong with the care they were getting. And that is invaluable. That was, I think, just to say, yeah, you're in a good place, they're doing the right thing. You can come back to me anytime. We can share care if you want. That should be the model that's run. And personally, I think that's a great way of doing it. And people should be receptive. Doctors should be receptive to that, and they should welcome it as well. If I had a patient with a rare condition that I saw once every 2 years, and somebody was out there offering to, it could be Queen Square in London or somewhere, see this patient for me, I welcome that with open arms, to be honest.
Yeah, and I think Shirley admitted to us on a previous meeting where we all see her along with yourself at the top of the tree there, and yet she she referred one of her patients on to somebody else once who may have had a better, the bigger picture of that particular patient's thing. So, and that's great to know that we can. And you also mentioned there shared care, which is something I've come across. And I think by that you mean we're seeing our haematologist, but we've had a telephone conversation with you, or we've seen you once, and you've kind of advised that person and oversee that from a distance, as it were.
Yeah. So, for example, I have a patient in Hereford. I know the guy there really well. He's great. He'll email me as and when he needs to. I've seen the patient once, and we just play it like that. And if he wants me to see the patient, I'll see them straight away. I think that works quite well. Or you could have you could split it, and some people have 6 months at the local centre, and then 6 months they go and see Shirley, for example. That's another way of doing it.
Yeah. You mentioned earlier MDT, I think. Is that the multidiscipline team that you're referring to? I've been talking to last week and today I've been speaking to some clinical nurse specialists in haematology, and it's occurred to me over those last couple of days that these individuals they're probably the key people in this whole story, aren't they? Because we're the patients, you're the clinicians up there at the top, and we struggle to get information sometimes from people like yourselves because you're so busy. But the clinical nurse specialist is absolutely key in this whole chain. I'm going to say she because that's the only ones I've ever met are ladies, but that's not being disrespectful. But they are a real key part of how we communicate, and certainly the ones I spoke to today and last week have reassured me that if I have a problem, all I've got to do is ring them up and they'll try and answer my problem. If they can't answer the problem, they'll come and see you or one of your colleagues and get back to us with an answer. So do you agree that the clinical nurse specialist is a really key part of this whole scenario?
Yeah, I don't think we'd survive without them.
Okay.
They take loads of phone calls every day. Often doctors are very bad at sometimes using medical lingo and maybe not so good at communicating as well as possible, and having a CNS who can go through things again is invaluable. That's one role. The other role is just to be there, so when you're not feeling right, just to pick up the phone and give them a ring. That's what they're there for. They'll give you their phone number, and they're the best contact. And of course, you develop a relationship with you. Hopefully, they don't leave or move around, which does happen, unfortunately. But you can develop a relationship over years with the CNS, and they're there for you.
And correct me if I'm wrong, but to the guys watching this, I know I've spoken to a couple of you, and I've had emails from you saying that you say you haven't got a clinical nurse specialist, or you've never had one. I was told today it is actually a requirement for cancer patients to have a clinical nurse specialist. So you have got one. If you don't know who it is, then either ring up the haematology department at your hospital or where you're treated, or your consultant secretary, and ask for the name and telephone number of your clinical nurse specialist. We have all got one. Am I right there, Guy?
That's right. Yes.
Yeah. Okay. So I know a lot of you have been saying that you don't know who that person is, but they're there, and I tell you, the ones I've spoken to over the last few days, absolutely amazing people, and they just want to help us. They want to help us. So yeah, second opinion. I've got a thing here about second opinion, but you've basically covered that, and it's something I've been harping on about for a long time. In fact, I got a call, an email late today from a lady. I don't know if she's watching. I can't even remember your name. Possibly Pamela. I think that's answered that question for you. You're not happy with the information you're getting from your haematologist, so go for a referral. Try and find out where the nearest centre is, specialist centre, and see if you can get yourself a referral there. I think I'm right, Guy, in that you have to ask your consultant or at least your GP for you to be referred. Is that correct?
That is correct. You need to be referred.
Yeah.
By a GP or a consultant.
Okay. So I'm going to try something now that we haven't tried, Kat. You need to keep your eyes open. Has anybody got a question for Guy? If you raise your hand, I can't see all the screens, but...
Christine was first and then Irene.
Okay, Christine.
Hi there. Yeah, I'm a bit remote on the Isle of Man, and they do a lot of work with Liverpool for the MDTs. But I've got a double whammy because I also have hemochromatosis, and I just wonder when you've got some, two conditions like that, both blood conditions, how my local person who's actually who has an interest in hematology gets the right information about any way that those two things might impact on each other, because obviously I'm a rarity, and if you're in a big center like UCL or something, there you might come across another person with both conditions.
Gosh, that's I have to say I've never come across that. So it's the first time. Yes, I can imagine that the two together may obviously affect things like if you have anemia, for example, then that could be a problem. I mean, I think obviously you're probably in a situation, I don't know, but you're in a situation where maybe shared care would work quite well, I guess. I don't know what the Isle of Man services are like, so
I think they have connections with people like Liverpool and the Christie, but I just wonder how do you get a question like that out to a wider audience of clinicians, so they might find another clinician who's also got a patient with the same profile.
I mean, I think the clever answer is the registry, because that, you need to be collecting data on hundreds of patients to kind of pick up associations between WM and other conditions, and that's the only way to do it. So that's the value of having a registry with 800 patients in it, or however many we've got now. You may start to understand that actually there's 3 or 4 patients who've got hemochromatosis as well, and then that should start ringing alarm bells.
Okay.
But unless you do that, you're never going to really connect with 2 uncommon conditions like that.
Okay, thanks.
I think you're in good hands in Liverpool. I worked there as a registrar years ago. So
right, but that's reassuring. Thanks, and sorry to the rest of the participants, because that's a bit of a personal question. So
no problem, Christine. Irina, I'm going to come to you in 1 second, but Guy, just talking about the registry. My understanding of the registry, it's a great, fantastic tool, but it's only as good as the hospitals that can put the data in, and not all hospitals do that. Is that correct? And if so, why?
I think there's 2 issues with the registry. One is the ridiculous bureaucracy and work there is just to get it open in your hospital, around the ethical issues around it. So that's a challenge, and then actually putting the data in is actually hard work. So the challenges are around time, really. So for example, I had a registrar help with the registry here, but without her I'd have really struggled. It's a lot of work to physically put the data in. I've got a colleague who's left, unfortunately, who's a good friend of mine, and he thinks that these computer systems should talk to each other, and we wouldn't have to manually put in information like your hemoglobin level and things, and it would all automatically populate from some hospital data. But unfortunately that's not the case, and we're still having to physically put data onto the registry, which is very time consuming. Okay.
Irene, you wanted to ask a question?
Yes, please. Good afternoon. I noticed in your PowerPoint presentation before, something about the MYD88 and CXC4R4, and that in the trials, the clinical trials must be considered and performed. So I would like to ask, is this mandatory? Because in the trials I participated, they never did it. No, they did it after I insisted a lot. And what's the benefit for us to know about these two genes transformation, mutation?
Well, the mid 88 is useful in terms of making a diagnosis. So if you have a patient where there may be some features that aren't completely typical, then having a mid 88 positive result is reassuring, in the sense that you can make a diagnosis of Waldenstrom's. I think it is important for trials. So we're trying to work out now whether these genetic defects are relevant in terms of treatment. So, for example, does a drug like ibrutinib work as well in people who've got a CXCR4 mutation? And therefore, to do that, the only way to do that is in these big trials. So that data is now, I think it's almost mandatory that's done in a trial, because we need to try and work that out. And at the moment, we're a bit in no man's land, I think, with the genetics. We don't really know in terms of it changing treatment. So it's critical we do that. I mean, we may find that a drug overcomes, you can have a CXCR4 mutation, but bortezomib overcomes it. I don't know. I'm making this up, but we'll only find that out if we look at it in every single patient who goes into a trial.
Yeah, this was really very important for me, because I had to insist a lot in order to have, this. And I would like also to ask something on the same thing. It can be, important to repeat these tests later on after treatments, or when a relapse happens. Could be any change in these mutations in the future, or this is once found and that's it?
The one that is probably more important is P53 change. So a lot of cancers have a deletion in P53, and that often occurs later on in the disease. So loads of different types of cancer have that, and that's again, it's not known at the moment, but I think there will be treatment that targets P53 deletion in 5 years. So again, that's an area where it is probably worth doing genetics in a relapse trial setting, and finding things like that out. I'm not sure about mid 88 won't change.
Thank you very, very much for
that. Does anybody else have a question for Guy? We've got about another 5 minutes. If anybody's got a question? I've got John Green there holding his hand up. John, you want to take yourself off mute?
Hey, thank you very much. Guy, in one of your PowerPoint slides, there was reference to NICE and licensed and approved drugs. Can you, obviously there's a nuance of meaning between the two. Can you explain what the difference is between something that's licensed by NICE and something that's approved by NICE?
Okay, so if a drug's licensed, that's nothing to do with NICE. That's it means it's been usually in the USA. It's been in a trial and it's shown to have some efficacy and is safe. and then it gets a license, and usually it comes to Europe, and there's a similar organization in Europe that will license it in Europe. So if a drug's licensed, it means that if you were a millionaire, you could have any drug that's licensed. The problem is it doesn't say who's going to pay for it. So lots of drugs are licensed, lots of fancy treatments are licensed that we don't have access to in the UK. So the problem in the UK is obviously we have a National Health Service, and you know, everything has to be looked at in terms of cost, and that's what NICE do. So if you've got private healthcare and it's extensive private healthcare, you can have anything that's licensed. But if you're in the National Health Service, you can have only things that are NICE approved in terms of cancer drugs.
Okay. Good.
And NICE,
thank you very much.
NICE drags behind things being licensed, unfortunately.
So, Guy, you told us that it's a bunch of guys like yourself writing the guidelines. Who are NICE? Who are they? What people are they?
They're health economists. They're often in the medical profession, or have been in the medical profession and then gone to NICE. Often high up in the medical profession, so experts in particular fields, and also there'll be doctors who get invited. So for example, ibrutinib was approved in relapse for WM, so I can't remember which one of us was involved. I think there was a few of us, it wasn't me. May have been Helen actually, and Shirley, Roger, I'm not sure. And then you've got WMUK as well will have got involved. So there's a whole broad range of people that get involved, and it's usually it's quite scary actually. There's usually 30 people in a room, and they drill you, they ask you some really hard questions.
Right, okay.
And of course the drug company as well.
Yeah.
So you know, Janssen make ibrutinib. It's really important that they'll be presenting all the data on it.
Right. Going to take one more question. And
hi.
Yeah, Tom. Yeah.
Right. Unless I missed it earlier, where would we be able to get a copy of the guidelines?
So they're not published yet, but they'll be on the British Society of Haematology website.
Tom, we've got a copy on WMUK, but they're 6 years or 7 years old. There's a copy on there, and as Guy has just said, the other ones are awaiting approval to be published, and I'm sure we'll publish them as soon as they are properly published. Yeah.
Fine. Thank you very much.
Okay, guys. Well, that's an hour. Guy, just want to say a big thank you so much for joining us tonight and giving us an hour of your time. We really do appreciate it. We appreciate everything you do for us at us WMers, and for us at WMUK as one of our trustees. So a big thank you very much indeed. Thank you everybody else.